what we'd like to do today is to provide a little bit of an overview and introduction to HIV telehealth. And it's appropriate that Dr. Spock and Dr. Ramers, Dr. John Scott, and I are all here because we kind of play different roles in Project Echo. And I'm going to start off talking about the kind of general Project Echo things. And John, feel free to jump in if you have comments, and then we'll move forward. I wear two hats at the University of Washington. One is as informatics specialist on this project. Another one is as program administrator over all of the projects here at the University of Washington, working with the Department of School of Medicine to implement, and different departments and divisions to implement Project Echo. And I wanted to take a step back to tell you what we're doing here at the University of Washington, how Echo is working, and then also talk about the origins with Dr. Sanjeev Arora. The whole mission of Project Echo is really to build capacity to manage the treatment of chronic and infectious disease in underserved and rural areas, monitoring outcomes as we go along. There's a big difference between what ECHO is and what telemedicine or telehealth 1.0 is, the traditional model of a specialist in an academic medical center speaking via camera or phone to a patient or a clinician. That doesn't really build capacity in the senses you can't really add any more specialty care units to that. But the whole process is to build capacity, and so with the ECHO model, we're trying to train clinicians and share knowledge and information so that they can begin to handle more and more complex cases on site themselves in the community clinics. Also, to catalyze knowledge sharing between clinicians developing different treatment expertise across the Pacific Northwest region. The whole idea is that your peers in similar circumstances with similar constraints on your clinic operations in rural and underserved areas are going to have information to share with one another, because treating HIV in these communities is very different than treating it at the academic medical center or here at Harborview. And finally, to disseminate treatment innovations quickly across the network of clinicians. And here I'm going to borrow an example from our hepatitis C ECHO and John Scott's clinic, in which the protease inhibitors were approved in May by the FDA, and in June and July, people who were part of our hepatitis C network, family practitioners, mid-levels, began rolling out protease inhibitor treatment and treating with protease inhibitors before most of the specialists in the country were doing so. And so we're hoping that as advances come through and as you come into this community of people, you'll be able to implement very quickly any changes in biomedical knowledge that come down the pike. Also, maximizing HIV care in local communities is very important. Treating patients locally with expert knowledge on site can be so very meaningful to patients, in particular from the psychosocial perspective. A clinician who knows the social and family context for a patient can be really critical in HIV care. A bit of a history of ECHO and telehealth lies squarely with Dr. Sanjeev Arora, who in 2002 was basically born out of frustration when he realized in the state of New Mexico, of which he was one of only a handful, I think of 2 or 3 hepatologists in the state, he had 30,000 patients hepatitis C positive and a 6-month wait, 6 to 8 months to actually get into his office. And he just couldn't figure out a way to stem the tide. He came up with ECHO as a way to build capacity. He didn't go one-on-one treating patients, but actually worked with teams of clinicians who were treating their own patients, and along the way amassed a number of really interesting awards, rolling this out in not only hepatitis C, but HIV and other infectious diseases, chronic pain, cardiac risk reduction, diabetes, and a whole host of others. Getting awards from the Ashoka Foundation for Disruptive Innovations in Healthcare and the American Association of Medical Colleges. And then in 2009, approached Dr. Scott about being the first replication site for Project ECHO here at the University of Washington. We've rolled it out across the WWAMI region since then in 4 domains: chronic pain, integrated addiction, psychiatry, hepatitis C, and now HIV. And so we like to say that Dr. John Scott is the first ECHO of ECHO here at the University of Washington, but has now been taken up in an urban context from the University of Chicago. Harvard is doing it. John Scott was instrumental in launching a hepatitis C ECHO in the University of Utah and Salt Lake and elsewhere. And so the expansion is ongoing. It's really gone viral, including some international settings as well. In 2011 was really a landmark New England Journal of Medicine article, because one of the critiques is, oh, this is a great program from a community perspective. There's been a large community response, but what about the quality of care that's actually being delivered on site, the ECHO model itself? And in a prospective cohort study, Dr. Arora took patients who were enrolled in ECHO sites, community health centers, federally qualified health centers, IHS clinics, and with mid-levels and family docs and internists, and said, okay, the patients enrolled there, what were their treatment outcomes in comparison to those patients actually making it into the academic medical center at the University of New Mexico? And this slide shows, just taken actually directly from the New England Journal of Medicine article, demonstrates that the treatment outcomes were roughly equivalent. What's of note here is that there were more minorities treated in the ECHO group, which was significant because traditionally some of these minority groups had a lower response to treatment. ECHO is an interactive learning environment, and when you present a case, you'll get interdisciplinary feedback from infectious disease, nursing, case management, and psychiatry. There may be differences of opinion, and we will model those for you because not all of medicine is heuristic-based or rule-based, in the sense that if situation A occurs, do action B. But the important thing is that you're also going to get feedback from your peers as well. And so as you listen to cases, think about what input you have about handling similar cases in your own clinic, how you structured the clinic, what your workflow is like, what your triage policies are like, given the constraints that you have to face. And this is information that is very helpful for the larger group to understand, and we build this knowledge together. And this is also important contextual knowledge that the specialists at the University of Washington don't really have. And so they might have some input on the biomedical perspective, but how to actually operationalize this in the community is a whole different ballgame. Dr. Aurora has published that this type of ECHO model decreases professional isolation, increases knowledge and self-efficacy to treat, and many people become referral resources as they build their panels out. Here at the University of Washington, ECHO is across 5 states: Alaska, Washington, Alaska, Wyoming, Oregon, Montana, and here's a kind of a distribution of the sites. At last count, it's a little bit outdated. We have 71 sites across the 4 domains of chronic pain, integrated addiction psychiatry, hepatitis C, and now HIV. And here, this is a closer-up version of the state of Washington. But really, that's just an overview. I'd like to turn it over to Christian Ramers to talk about the HIV program here at the NWAETC.
All right, thanks, Kent. So for the second half of this introduction, I'm just going to talk more specifically about the NWAETC ECHO program. And what we've done is basically standing on the shoulders of Sanjeev and John Scott and Kent, kind of customize this to the HIV world within our NWAETC work. So one thing that we had to adapt is something that we call the tiered concentric participation model. And this is because our real target in this grant is the people in Tier 1, which is those of you on the video line, really providers that are lower volume providers, kind of the grant language around 25 patients or less. And that's where we're going to continually focus the cases and most of the discussion so that we can really build capacity from that level. However, with all the effort that we're putting in to make this a good product, we didn't want to spare other people that wanted to get involved, and so we're allowing people to observe in a Tier 2 fashion using a different platform, using Adobe Connect. And that's going to be a little bit less interactive, and the cases probably won't come from those Tier 2 sites. They'll be coming from the Tier 1 sites. In Tier 3, we're actually going to save these didactics that start each session, and people that are not involved in the program or want to just check it out or couldn't make a program will be able to watch these mini didactics, not the whole session, but just the first 15 minutes on demand, and these will be archived at our website. So the mechanics of how the session actually looks here is that we'll start every session as close to exactly 12 o'clock as we can with a mini didactic, and this will be a focused clinical topic, hopefully lasting 15 minutes and no longer, and then we'll have a 5-minute period for discussion. And this section in blue will be actually recorded and archived for future viewing, so if you happen to miss a session, don't worry, you can always see that on our website. Right after the discussion part, we'll do a quick roll call to see everybody that is present at the session. And then as you can see, the remainder of the hour, basically 40 to 45 minutes, will be all devoted towards case consultations. Our goal is to do about 3 to 4 cases per session. This is HIV, so it's a little bit different from hepatitis C, a little less protocolized, and each case we'll probably have to dig in a little bit more. But we're hoping to spend 5 to 10 minutes on each case, which would give us about 3 to 4 per session. We're hoping that each site is able to contribute at least 1 case per month, and we think if we do that, we'll have an adequate volume to kind of fill things out for the next couple of weeks. So a couple things about etiquette. I'm going to talk about 3 different aspects of telehealth etiquette. This is a new thing for a lot of people. The first is just the bare bones. Please mute your microphone. This is a technology that people aren't all that used to. and we have to sort of be responsive to that. If you have something to say, just we'll allow you a second or two to get yourself off of mute. The telephone is always an option if you can't connect, if you're having technical difficulties, but we'd prefer that you actually use your video through Adobe or through your Polycom desktop. If you're having major technical issues and you're just not getting a picture, the telephone is always the backup, and you can always email or text us during the session with problems rather than kind of interrupt the session, because everyone else that is on, it wouldn't be fair to them. Secondly, in terms of educational goals, we really want to create a positive learning environment, and this is something I think is analogous to a rounding team in the hospital, for example. If you have medical students and residents and fellows, people are coming to this meeting really from all different kinds of levels, and we want to validate every type of question that people have. Everybody here has something to learn from everyone else. And so we're going to really encourage everybody to ask the questions that they have, and we want to encourage people to present cases, not only the experts, but especially those just learning how to do HIV and those with just single-digit patient panels. We want them to be the real focus of the sessions. And as I said, the target is really on the low-volume provider. And as I said, there's a lot to learn from everyone. We certainly have a lot to learn here from Seattle, from you all in the network as well. And lastly, kind of on the metaphysical plane, this is a new medium, and so we're going to be learning as we go, and we just ask you to tolerate some glitches. If you don't get logged on to the first session, we'll fix it within a week, and we hope things will go smoothly after then. And I'd just like to say that, treating HIV, this is a real team effort. So treating HIV is a lot more like soccer than golf. This next slide, there's a saying that is the motto of my favorite Angolan soccer team, which is "A união faz a força." And what it means really is that we're all stronger together. And I think the power of this model is that it's not just us and you, it's not just Seattle and the Waimea region, we're all creating a network together. So as Kent mentioned, we want you to listen to cases, not just waiting for your turn, not just waiting for next week when you're going to present your own patient, but everybody's here to contribute. So when you're listening to the cases, think about strategies that you've used in a similar case. Think about what you've seen done in your own community, because chances are it really would be helpful to the person presenting the case. So we want you to think about different ways to diagnose, different treatment decisions, and then beyond just the biomedical things, what about case management, communication strategies when things like adherence come up? How can we speak to patients in a little bit of a different way? And then on a more systemic level, are there processes that you can put in place in your clinic that would help things work a little better? Keep in mind, a lot of clinics that are involved are community health centers that may not be structured the way traditional Rhine-wide clinics are. So we need to think of processes that will make care better. And we really will invite you to share. It's kind of my job after each case to make sure that everybody has a chance to speak up during the conference and offer their own opinions or their own suggestions. And if you think of something afterwards, just send me an email and I'll make sure that it gets to the right person. So now to some more of the details of how we're going to actually go through the cases. Case presentations, we hope to come on this case presentation form that you see up here. We've been sort of refining it, so we're now up to version 3, I think, making it better. And each case that is presented will have an ECHO ID code, which will start with the location that you're coming from, as well as your initials and the number, just the numerical order of which patient you're presenting. So for example, if I'm presenting from Seattle, the first patient would be SEA-CBR1. If you have trouble figuring this out, you can just email Natalia and she'll assign a code for you. We want case presentations faxed to us to the number that you see there by Tuesday evening, if possible, so that we can have time to get it to our specialists to review on Wednesday. And I'm sure you're asking yourselves, what makes a good case? Do I really have to wait until I find the case that I wanted to write up that's just the most spectacular example of something? And the answer is really no. Anything that's important to you in your clinical practice that brings up an interesting clinical question is perfectly appropriate to present in Project ECHO. Our goal is to really grow as a network and share best practices, even if it's things as simple as what to start an initial regimen for a patient that just walks into your door. We want to focus really on the fundamentals and share best practices here. And as I said, the expectation is that each site will present one case per month. We have an evaluation component to this program as part of the grant, and also just part of good practice to see if this is effective and to see if this kind of thing can be replicated. You should have received or will be receiving 2 types of assessments, one at the clinic level, which will be done just annually every 12 months, And this really just takes standard clinical quality measures which are used throughout Ryan White and other care programs. If you haven't done that yet, we'll hopefully get that to you within a week. And secondly, we want to assess individual providers. This will be done every 6 months, and this is to identify your own goals as a provider and to look at your knowledge regarding HIV, self-efficacy, and whether you feel like you're part of a community of practice. And then thirdly, this is more behind the scenes. We here in the room are tracking a lot of things, how many cases are presented, which recommendations are done, and also how many peer-to-peer interactions we have. We really want to encourage you out in the network to interact with each other, and as I said, speak up on the cases. So what are the resources for you out there participating? First of all, we're doing one now. This is the only mini didactic where we won't talk about an actual clinical topic, but starting next week, there'll be really useful clinical focused topics. The main thing that's bolded here is presenting cases. That's kind of what it's all about, is for you to get multidisciplinary opinions back on your cases, get in better practice to build your own capacity. I've kind of laid it all out here in terms of how to get a hold of me. Everything except my home address, I think. So if you have any questions at any point after the session or something that comes up in between the session, please get a hold of me. I think with all those numbers, you should be able to find me. And also, I'm happy to serve as the conduit for any of our other panelists, our psychiatrists, or pharmacy questions. I'm happy to just send the message where it needs to go. We're going to be sending out email announcements, and these are going to get more robust as we go with sort of hot topics in the news and with articles of interest related to our sessions. And then lastly, I'd point you to our website, which is constantly evolving and under construction, but it's getting better every day. And this is where we're going to archive our video sessions if you happen to miss a session. There's going to be a repository for forms that you'll need there, of course, our contact info, and information about upcoming sessions. There's just proof that the website actually exists. There it is. It's getting better every day. On the left here will be different categories of where you can find different things to do. So I'm going to finish just showing you what our map looks like. It's kind of overlaid on the existing ECHO map. And the sites here in blue are our Tier 1 sites, which you will hopefully see a lot on video. There's these additional sites in green, which are Tier 2 sites who will be probably observing us on Adobe Connect sessions, but also texting us questions. And what I'm going to do now in finishing up is allow us to introduce ourselves a little more substantially than we would in a regular ECHO session. So I think we'll go around and ask if people can just introduce who's in the room and then just maybe one line about what type of clinic it is that you're working in.